Welcome to Nightshift Pulse. Comment your city and the time below. The night connects us all. If you enjoy what you hear, please subscribe. Let's step into the dark. Story 1. The charge nurse's vanishing trauma bay. I stood in front of Trauma Bay 3 staring at the sealed renovation doors while my tablet insisted someone was inside receiving active treatment. The digital board showed vitals, heart rate 112, blood pressure dropping, oxygen saturation at 89%. I could see the yellow caution tape stretched across the entrance. I could see the lock, but the system was logging interventions in real time, and the initials administering care were my own. I have been the night charge nurse in the emergency department at Mercy General for 17 years. In that time, I have learned to trust systems, digital boards, electronic charting, automated alerts. These tools do not lie. They do not fabricate. They reflect what staff input, what monitors detect, what actually occurs within these walls. So when Trauma Bay 3 began appearing occupied on my tablet 3 weeks ago, I assumed it was a software glitch, something maintenance would resolve during their next update cycle. Trauma Bay 3 had been closed for renovation since early September. The hospital administration decided to expand the space, add newer equipment ports, update the ventilation system. I watched them seal the room myself, saw the construction crew remove the monitoring equipment, disconnect the oxygen lines, strip the space down to bare walls. Yellow caution tape crisscrossed the entrance. A laminated sign read "Closed for renovation, no entry, authorized personnel only." The digital bedboard should have shown the bay as unavailable, grayed out in the system, removed from our active treatment spaces. Instead, every third or fourth night, usually between 2 and 4 in the morning, the bay would flicker back to life on my screen. The first time it happened, I was reviewing staff assignments at the central station. My tablet chimed, a soft notification indicating a new patient placement. I glanced down and saw Trauma Bay 3 listed as occupied, status yellow, meaning stable but requiring observation. I frowned, tapped the entry to view details, and found a patient chart that should not exist. No name, just a medical record number I did not recognize. Admission time stamped at 0213 hours. Chief complaint listed as blunt force trauma, evaluation in progress. I walked down the corridor to physically check. The caution tape remained intact. The doors were locked. Through the narrow window, I could see the gutted interior, exposed pipes, disconnected monitor mounts, construction debris on the floor. No patient, no staff, no treatment occurring. I returned to the station and refreshed my tablet. The entry had disappeared. I told myself it was a database error, some fragment of old data resurfacing during a system backup. I made a note to contact IT in the morning. By the time my shift ended, I had almost forgotten about it, but it happened again 4 nights later. Same time frame, 0221 hours, same status indicator. This time the chart showed vitals. Heart rate 108, blood pressure 95/62, respiratory rate 18, oxygen saturation 91% on room air. The data updated in real time as I watched, numbers shifting every few seconds as though monitors were actively tracking someone. I walked back to Trauma Bay 3, locked, empty, silent. When I returned to my tablet, I noticed something I had missed before. The staff initials logged under attending nurse were mine, JM, my credentials, my login signature. According to the chart, I had been providing care in that sealed room for the past 23 minutes. I checked my badge access log. No entry recorded for Trauma Bay 3. I had not scanned my badge there. I had not been inside. I had been at the central station the entire time, visible to 3 other nurses and our unit secretary. I reported it to IT the next morning. They assured me it was a known issue with legacy data not purging correctly after room closures. They would push a patch. It would not happen again. It happened again that same night. This time I was prepared. I screen captured the chart, documented the exact timestamp, and walked immediately to the bay. I pressed my face against the narrow window, cupping my hands around my eyes to block the hallway light. The room was dark, gutted, unchanged. But as I stood there, I thought I saw something, a faint depression in the corner where the stretcher used to be positioned, as though weight had recently pressed into the dust-covered floor. Not footprints, something heavier, more concentrated, the shape of a body. I tried my badge against the locked door, access denied. I radioed security to open it. The officer arrived within 3 minutes, scanned his master key, pushed the door open. We stepped inside together. He swept his flashlight across the space. Exposed wiring, stacked drywall panels. A contractor's toolbox near the far wall. No stretcher, no patient, no equipment that could generate vitals. But the air felt wrong, warmer than it should be. And there was a smell, faint, clinical, like alcohol prep wipes and iodine. The smell of active treatment. The officer looked at me with polite confusion. I thanked him and said I must have misread my screen. He sealed the room again and left. My tablet still showed Trauma Bay 3 occupied. I opened the chart fully this time, scrolling through the documentation. Nursing notes appeared, detailed, thorough, written in the clipped shorthand I used during busy traumas. Patient responsive to verbal stimuli. Abrasions noted bilateral upper extremities. Cervical collar applied. IV access established left antecubital, 18 gauge. Normal saline initiated at 125 milliliters per hour. Awaiting radiology transport. I had written none of this. But the phrasing, the abbreviations, the clinical cadence, it was mine, unmistakably mine. I scrolled further. Timestamp updates continued. Medications administered. Wound care completed. Radiology returned. Film showed no acute fractures. Patient condition stabilizing. Disposition pending. I watched the chart update in real time for 40 minutes. Then abruptly it closed. Status changed to discharged. Disposition left without being seen. The entry vanished from my board. I did not sleep well that day. The pattern continued. Every few nights, always in the early morning hours, Trauma Bay 3 would populate on my system. Always with my initials as the attending nurse. Always with plausible, detailed documentation that I had not written. The cases varied. Motor vehicle collision, fall from height, assault, laceration repair. But the timestamps were always historical. Dates and times from years ago, cases I could not specifically remember, but that felt uncomfortably familiar. I began searching old records, cross-referencing the medical record numbers that appeared in these phantom charts. Most returned no results. A few matched patients from years prior, individuals I had cared for during my early years in the ER. But the details did not align. The documented interventions in the phantom charts described treatments slightly different from what I remembered. Outcomes that diverged from reality. One entry disturbed me more than the others. It appeared on a Sunday morning, 02:47 hours. The chart showed a trauma case from 6 years ago, a patient I remembered clearly because he had died despite our efforts. Severe head injury from a motorcycle accident. We had worked him for over an hour before calling it. I remembered the attending physician's face, the quiet weight of failure, the way I had mechanically cleaned the bay afterward, removing blood-soaked linens, resetting the space for the next case. But the phantom chart did not show a death. It showed a recovery. It documented interventions I had performed, medications I had administered, but with subtle differences. A slightly altered dosage here, A repositioned airway there. Small variations that, according to this version of the chart, had resulted in stabilization, transfer to ICU, eventual discharge. A version where he survived. I stared at the screen, my hands shaking. I remembered that night. I remembered the mistakes I had made. The delayed intubation, the miscalculated medication dosage. The seconds I had wasted second-guessing myself. I had replayed that case in my mind for months afterward, wondering if I could have done something differently. This chart was showing me what I had wondered. It was showing me the version where I had made the correct choices. But it was not real. It had not happened. Or had it? I began to doubt my own memory. I pulled the official records from 6 years ago. They confirmed what I remembered. The patient had died. But sitting there in the quiet of the empty corridor, staring at two conflicting charts, I felt something inside me fracture. Which version was true? Which version had I lived? The phantom charts appeared more frequently after that, almost every shift. Different cases, different patients, but always with my initials, always documenting care I did not remember providing. I stopped reporting it. I stopped asking others if they saw the entries. I knew they would not. This was something between me and Trauma Bay 3. Last week, I finally broke protocol. I obtained a physical key to the bay from maintenance, claiming I needed to inspect the renovation progress for administrative purposes. I waited until the early hours, until the phantom entry appeared on my tablet. Then I unlocked the door and stepped inside. The room was unchanged, gutted, dark, empty. But my tablet showed me standing beside a patient, monitoring vitals, adjusting IV flow rates. I could see my own location icon on the digital floor plan positioned exactly where I stood. And I could see the treatment documentation updating in real time. Actions I was supposedly performing at that very moment. I raised my hands in front of me. They were empty. I was touching nothing, treating no one. But the chart insisted otherwise. I stood there for nearly an hour watching myself provide care to a patient who did not exist, in a room that was not operational, documenting a reality that conflicted with everything I could see and touch and verify. When I finally left, the chart closed itself. Disposition. Transferred to ICU. I have not opened Trauma Bay 3 since. But it still appears on my board, still shows my initials. Still documents cases I cannot remember and cannot verify. I think the system is keeping a record of something I was supposed to do, or something I did do in a version of events I can no longer access. I do not know which possibility frightens me more, that I am losing my memory of my own actions, or that the system is showing me a version of myself I failed to become. Either way, Trauma Bay 3 remains occupied. And somewhere in the data, I am still inside, still working, still trying to save someone I cannot see. Some patients never leave the system even after their rooms are sealed and renovated. And some nurses never stop treating them, even after they have forgotten why. Story 2. The triage nurse and the patient without vitals. He sat in the waiting room chair with his hands folded neatly in his lap, telling me his symptoms in a calm, measured voice. Chest tightness, mild dyspnea, onset 30 minutes ago. I wrapped the blood pressure cuff around his arm, pressed start, and watched the machine cycle through its measurement protocol. The screen blinked twice, then displayed 3 zeros, heart rate 0, blood pressure 0/0, oxygen saturation 0%. I looked at him. He smiled politely and asked how much longer the wait would be. Triage is a practice of sorting, of categorizing, of making rapid decisions about who needs immediate intervention and who can safely wait. After 9 years working the triage desk in the emergency department at St. Catherine's Hospital, I have developed an internal algorithm. I assess acuity within seconds. Skin color, respiratory effort, level of consciousness, pain scale, mechanism of injury. I trust my instincts and I trust my equipment. The pulse oximeter does not lie. The blood pressure cuff does not fabricate. The thermometer does not invent fevers. These devices provide objective data that guides my clinical judgment. So when a patient walked into my triage bay at 11:43 on a Tuesday night and every device I used returned impossible readings, I assumed equipment failure. He was a man in his mid-40s, average build, unremarkable features. He wore gray slacks and a blue button-down shirt, slightly wrinkled, as though he had come directly from an office job. He approached my desk with steady gait, no visible distress, no clutching of chest or abdomen, no labored breathing. He sat down when I gestured to the chair and stated his chief complaint clearly. "Chest tightness," he said. "Started about 30 minutes ago. Not severe, but persistent. Some difficulty taking a full breath. Standard presentation, possible cardiac origin, possible anxiety, possible musculoskeletal." I began my assessment, asking the usual screening questions. Any radiation of pain, any nausea, diaphoresis, dizziness, any history of cardiac issues? He answered each question calmly, providing appropriate detail. No radiation, no associated symptoms, no prior cardiac history. He had been sitting at his desk when the tightness began. He had waited to see if it would resolve, then decided to seek evaluation. I reached for the pulse oximeter, the small clip device that measures oxygen saturation and heart rate through the fingertip. I attached it to his right index finger, waited for the sensor to acquire a signal. The device beeped its usual confirmation tone. The screen illuminated and then displayed heart rate 0, SpO2 0%. I frowned, removed the device, checked the sensor window for obstructions, clean. I tried his left hand. Same result, 0 and 0. "Equipment's being temperamental tonight," I said, keeping my voice neutral. I reached for the manual blood pressure cuff and stethoscope. I wrapped the cuff around his upper arm, positioned the stethoscope over his brachial artery, and began inflating. I pumped the bulb, watched the gauge rise, then slowly released the valve, listening for the characteristic sounds that indicate systolic and diastolic pressure. I heard nothing. No pulse, no blood flow sounds, just silence. I deflated the cuff completely and tried again, concentrating. I pressed the stethoscope more firmly against his skin. I inflated past 200 millimeters of mercury to ensure I had not missed the systolic peak. Then I released slowly, listening with absolute focus. Silence. I looked at the patient. He sat quietly, watching me with polite patience. His skin had normal color. His chest rose and fell with regular respirations. He showed no signs of distress. "Are you feeling all right now?" I asked. "Any worsening of the chest tightness?" "No change," he said, "still just a tightness. Not painful exactly, more like pressure." I tried the automated blood pressure machine, the digital unit we use for rapid screening. I positioned the cuff, pressed start, watched the machine cycle. It hummed, inflated, measured, deflated, then displayed. 0 over 0. Heart rate 0. 3 different devices, 3 sets of impossible readings. I excused myself and retrieved a different pulse oximeter from the supply cabinet, a backup unit I knew had been calibrated recently. I returned, applied it to the patient's finger. 0 and 0. "I am going to be honest with you," I said, choosing my words carefully. "My equipment is not registering your vital signs correctly. I am going to have you moved directly into a treatment room so we can use the cardiac monitors and get accurate readings." "Of course," he said, "whatever you think is best." I logged his information into the system, creating a new patient chart. Name, date of birth, chief complaint. I reached the section for vital signs, required fields, cannot advance without data. I stared at the empty boxes, then typed what the machines had shown. Heart rate 0, blood pressure 0/0, respiratory rate. I counted manually, watching his chest. 14 breaths per minute. I entered 14. Oxygen saturation 0%. The system accepted the entries without error flags, without alerts, as though these readings were plausible. I assigned him to room 7 and called for a tech to transport him. I expected the system to trigger an automatic critical alert. Vital signs incompatible with life should generate an immediate notification to the attending physician, flagging the patient as emergent. But the alert did not sound. The chart simply saved, status updated to roomed, and appeared on the main tracking board with a yellow indicator, meaning stable but requiring physician evaluation. The tech arrived, asked the patient to follow him. The patient stood, thanked me politely, and walked down the corridor toward room 7. I watched him go, his gait steady, his posture normal. I checked my screen again, reviewing the chart I had just created. The vital signs I had entered were still there, zeros across the board. But beneath them, in the medication administration section, new entries had appeared, entries I had not typed. Aspirin 325 milligrams administered orally at 23:49 hours. Nitroglycerin 0.4 milligrams sublingual at 23:52 hours. IV access established, left forearm 20-gauge catheter, normal saline initiated. I stared at the timestamps. 23:49 was 6 minutes ago. 23:52 was 3 minutes ago. I had not given this patient any medications. I had not started an IV. He had been in my triage bay, then walked to room 7. No one had treated him yet. I navigated to the system's audit log, the back-end record that tracks every user action, who charted what, when, and from which terminal. The log showed my user ID associated with those medication entries. According to the system, I had documented administering those drugs. I had not. I stood, intending to walk to room 7 and clarify the situation with whichever nurse was assigned to the patient. But as I moved toward the corridor, I glanced at the waiting room. The patient was sitting there again. Same chair, same posture, hands folded in his lap, staring calmly at the triage desk. I stopped, looked back toward the hallway leading to room 7. Looked again at the waiting room. He was in both places. No, he was waiting again. He had returned to the waiting room. But the tracking board still showed room 7 occupied, his chart still active in the system. I approached him slowly. "Sir, you were just taken back to a room. Did you need something from the waiting area?" He looked up at me, his expression pleasant but blank. "I am still waiting to be called back," he said. I gave my information to the nurse at the desk. She said someone would call me. "I am the nurse at the desk," I said. "I triaged you 10 minutes ago. You were taken to room 7. He tilted his head slightly as though considering this. "I do not think that happened yet," he said. "I have been waiting here since I arrived." I checked my watch. 11:57. I checked the timestamp on his chart. Initial triage documented at 23:43. Current time aligned. But subjectively it felt like I had been interacting with this patient for much longer. "Can you describe your symptoms again?" I asked. "Chest tightness," he said. "Started about 30 minutes ago, not severe but persistent. Some difficulty taking a full breath." Identical phrasing, same words, same cadence. Not approximate, exact. I returned to my terminal, pulled up his chart, scrolled through the documentation. The medication entries were still there, time-stamped minutes before the current time. But now there were additional notes, progress updates written in my phrasing, documenting reassessment, continued monitoring, stable condition. I had written none of it. I walked quickly to room 7. I pushed open the door. The room was empty. Bed neatly made, monitors off, no indication anyone had been inside recently. I returned to the waiting room. He was still there, sitting calmly. I checked the tracking board. Room 7 still showed occupied, his name listed status yellow. I decided to re-triage him, to restart the process and document what was happening. I called him back to my bay. He stood, walked over, sat down in the same chair. Chest tightness, he said before I could ask. Started about 30 minutes ago, not severe but persistent. Some difficulty taking a full breath. Exact words, exact delivery. I reached for a different pulse oximeter, one I had not yet used on him. I clipped it to his finger, 0 and 0. I tried a tympanic thermometer, checking his temperature. The device beeped, displayed 94.6 degrees Fahrenheit. Low but not impossible. I documented it. I asked him to open his mouth so I could visualize his oral mucosa, check for cyanosis or pallor. He complied. His mouth looked normal, moist, pink, healthy. But when I glanced at my screen, the chart had updated again. New medications listed. Morphine 2 milligrams IV push. Zofran 4 milligrams IV push. Continuous cardiac monitoring initiated. I navigated back to the audit log. My user ID. My credentials. Entries I had not made. Do you remember coming here before tonight? I asked him, changing my approach. I came here tonight, he said, when my chest tightness started. Before tonight. Have you been to this emergency department previously? He paused, his eyes losing focus briefly as though accessing a distant memory. I am not sure, he said finally. I think I might have, but I do not remember when. I pulled up the patient database, searched his name and date of birth, looked for prior visits. The system returned 11 previous encounters spanning the last 14 months. I opened the first one, dated 13 months ago. Chief complaint, chest tightness. Triage nurse, my name. Vitals, all zeros. Disposition, left without being seen. I opened the second encounter, 8 months ago. Same complaint. Same nurse, same vitals, same disposition. All 11 visits, identical presentation, identical documentation, identical outcome. I looked at the patient. He was watching me, his expression unchanging. You have been here before, I said carefully. Multiple times. Do you remember any of those visits? I remember waiting, he said. I remember sitting in this chair. I remember talking to you. Do you remember being treated? Do you remember seeing a doctor? I remember waiting, he repeated. I checked the current chart again. The medication list had expanded. Heparin bolus. Cardiac enzyme labs ordered and resulted. Troponin elevated. Cardiology consult requested. All interventions I had not performed documented under my credentials, time-stamped in the immediate past. I stood and walked back to room 7, moving quickly, ignoring the strange looks from other staff. I pushed the door open, still empty. I checked room 8, empty. Room 9, a real patient, a woman with abdominal pain accompanied by her husband. I apologized for the interruption and left. I returned to the waiting room. He was there in the same chair, same posture. But now there were 2 of him, side by side, identical, both staring at the triage desk with the same patient expression. I blinked, looked away, looked back. Only one now. I checked my watch, 12:17. I checked the timestamp on the chart, initial triage, 23:43. But I had been interacting with this patient for over 30 minutes. The timeline did not align with the documented start. I pulled up the tracking board looking at the full ER census. Room 7 still showed his name, still showed active treatment in progress. but there were now 3 additional entries scattered across the board. Rooms 12, 15, and 18. All with the same patient name, same medical record number, same chief complaint, same vital signs. All documented by me. 4 instances of the same patient simultaneously occupying 4 rooms, all being treated by me, all with charts that updated autonomously. I searched the system logs for any other nurse's interaction with this patient. No results. Only my user ID appeared in the records. I was the only staff member who had documented anything related to him. I was the only one who could see him. I walked back to the waiting room one more time, slowly now, my hands trembling. He was still there, sitting in the chair. But as I approached, he turned his head and looked directly at me. And for the first time, his expression changed. He smiled, a small, knowing smile. "You remember now, do not you?" he said. "Remember what?" I whispered. "The night I came in," he said. "The night you were alone at triage. The night you were overwhelmed, exhausted, running behind. The night you saw me sitting here and thought just for a moment that you could skip my triage, that you could let me wait a little longer, that no one would notice." I felt something cold settle in my chest. "I do not remember that," I said. "You told yourself I looked stable," he continued. "You told yourself you would get to me after the next critical case. You told yourself it would be fine. I triage everyone," I said. "I do not skip patients." "You saw me," he said. "You made a decision, and I waited. I sat here and waited, and while I waited, the tightness in my chest became pain, and the pain became infarction. And I kept waiting because you told me to wait." "That did not happen," I said, my voice breaking. "It is happening," he said. "It is always happening. Every night I come back, and every night you decide to make me wait. And every night I sit here while my heart stops, while my vitals zero out, while your system tries to document the care you meant to provide but did not." I backed away from him, my breath shallow. I turned and nearly ran back to my terminal. I pulled up the oldest chart in his record, the first visit from 13 months ago, and expanded the full documentation. I read through my triage notes, the ones I had supposedly written, and found a timestamp gap, a 47-minute delay between his documented arrival and my initial assessment. 47 minutes where he had been checked in, logged into the system, and then left waiting while I managed other cases. I scrolled to the final entry. Time of disposition, 0132. Outcome, patient found unresponsive in waiting area. Code blue initiated, resuscitation unsuccessful. Time of death, 0151. I remembered that night now. I remembered the chaos, the critical traumas that had flooded in simultaneously. The impossible decisions about who to assess first. I remembered seeing him in the waiting room, noting that he appeared stable, telling myself I would get to him soon. I remembered the overhead announcement, code blue waiting area, and the sick realization as I ran toward the sound. I remembered his face, pale and still, as we worked on him. I remembered the attending physician calling the time. I remembered the way I had mechanically returned to my desk afterward, logging the outcome, closing the chart, and forcing myself to continue working because there were other patients waiting. I remembered burying it, refusing to think about it, telling myself there was nothing I could have done differently, that he had not presented as critical, that triage requires prioritization and sometimes people wait. But he had not stopped waiting. I looked at the tracking board now, and his name was everywhere, multiplying across every room, every status indicator yellow, every chart updating with treatments I had wished I had provided, interventions that might have saved him if I had triaged him immediately instead of making him wait. The system was completing a version of his care that had never happened, documenting the timeline where I had made the right choice, where I had assessed him first, where I had recognized the severity and acted. But that version existed only in the database, only in the autonomous updates to his chart. In reality, he had waited and died. I do not know how long I sat there staring at the screen, watching his charts update with phantom interventions. Eventually, the entries stopped. One by one, the rooms cleared. Statuses changed to discharged, disposition for all, left without being seen. The waiting room is empty now, but every few nights he returns. Same chair, same complaints, same vital signs, and every time the system asks me to triage him again, to make the same decision, to choose whether he waits or whether he is seen immediately. I always choose immediately now. I document his acuity as critical. I assign him to a room within seconds. But the system knows the truth. The system remembers what I did the first time. And no matter how many times I try to correct it, his chart always ends the same way. Some patients never stop waiting, even after you have learned your lesson. And some nurses never stop triaging them, trying desperately to change an outcome that has already been written. Story 3, the trauma nurse is repeating code blue. The alarm was unmistakable. A 3-tone chime that had been decommissioned 8 years ago when the hospital updated its emergency alert system. But I heard it clearly, echoing through the empty corridor at 3 in the morning, followed by the automated voice. Code blue, storage room 4B. I grabbed the crash cart and ran, my badge swinging against my chest. When I arrived, 2 other nurses were standing in the hallway, staring at me with confusion. "What code?" one of them asked. "Nothing came through on our phones." I have been a trauma nurse at Riverside Medical Center for 12 years. In that time, I have responded to hundreds of code blues, the urgent alerts that signal a patient in cardiac or respiratory arrest, requiring immediate resuscitation efforts. The code blue system is standardized, reliable, and impossible to ignore. When the alarm sounds, it transmits simultaneously through overhead speakers, staff phones, pagers, and the central monitoring station. Every clinician within the hospital hears it. Every available responder converges on the specified location. So when I began hearing code blue alerts that no one else could hear, I knew something was profoundly wrong, either with the system or with me. It started on a Friday night 4 weeks ago. I was restocking supplies in the trauma bay, organizing IV kits and intubation equipment. The ER was unusually quiet. Only 6 patients in the department, all stable, no traumas en route. The kind of night where you allow yourself to hope you might finish your shift without blood on your scrubs. At 02:47 hours, I heard the alarm. It was not the current code blue tone. A sharp, urgent electronic pulse followed by a digital voice announcement. This was the old tone, the one the hospital had used years ago before the system upgrade. A 3-note chime, almost melodic, followed by a calmer, more measured voice. Code blue, storage room 4B. Code blue, storage room 4B. I froze. The supply kit half opened in my hands. Storage room 4B was not a patient care area. It was a storage space in the basement level used for archived equipment and old records. I had not been down there in years. But a code blue is a code blue. I dropped the supplies, grabbed the nearest crash cart, and started moving. I expected to see other staff responding, expected to hear the rapid footfalls of the code team, expected the overhead announcement to repeat. But the hallways remained quiet. No one else was moving. No phones were buzzing. I stopped at the central station where 2 other nurses were reviewing charts. "Did you hear the code?" I asked. They both looked up, confused. "What code?" "Code blue, storage 4B. One of them checked her phone, shook her head. "Nothing came through. Are you sure?" I was sure. I had heard it clearly, but their phone showed no alerts. The overhead system had not activated. The digital tracking board showed no code in progress. "Maybe I am just overtired," I said, forcing a smile. Long week, but I could not shake the feeling. I made my way toward the stairwell that led to the basement level, telling myself I was being ridiculous, that I was chasing a phantom sound. I descended the stairs, pushed open the heavy door at the bottom, and walked down the dimly lit corridor toward storage room 4B. The door was closed. I pressed my ear against it, listening. Silence. I turned the handle. Unlocked. I pushed it open and reached for the light switch. The room was exactly what I expected. Metal shelving units stacked with old equipment, boxes of outdated forms, decommissioned monitors covered in dust. No patient. No staff, no emergency. I stood there for a moment, feeling foolish, then turned to leave. As I reached for the door, I noticed something on the floor near the far corner. A clipboard lying face down. I walked over and picked it up. It was a code blue documentation sheet, the kind we used to use before everything went digital. Handwritten entries, spaces for timestamps, interventions, medications administered, rhythm checks. The paper was yellowed, aged, but the ink looked relatively fresh. I scanned the entries. Patient name, blank. Medical record number, blank. Code initiated 0247, initial rhythm asystole. CPR started, epinephrine 1 milligram administered, no change. Continued compressions. The timestamp matched the alert I had heard. 0247, but the date at the top of the sheet was from 9 years ago. I folded the paper, slipped it into my pocket, and left the room. I returned to the ER, unsettled but trying to rationalize. Old paperwork. Coincidence. Stress-induced auditory hallucination. But 3 nights later, it happened again. Same time. 0253 hours, same tone, same voice. Code blue, storage room 2C, code blue, storage room 2C. I was in the hallway when I heard it, restocking a linen cart. I looked around, expecting to see other staff reacting. No one moved. I pulled out my phone, checked for alerts. Nothing. I walked to the nearest nurse. "Did you hear that?" "Hear what?" "The code." She shook her head, already turning back to her work. I went to storage room 2C, another basement space, this one filled with old stretchers and broken equipment waiting for disposal. The room was dark. I flipped the light, scanned the space, found another clipboard on a shelf near the door. Same type of code blue sheet, same aged paper, same handwriting style. Date, 11 years ago. Time of initiation, 0253. I started keeping a log. Every time I heard the phantom alarm, I documented the time, location, and what I found. Over the next 2 weeks, I heard 9 separate code blue alerts, all in the old tone, all referencing storage areas or decommissioned rooms. Each time, I was the only one who heard it. Each time, I found a clipboard with documentation from years past. The timestamps always matched the moment I heard the alarm. But the dates were historical, ranging from 6 years ago to 14 years ago. I began to recognize patterns in the handwriting on the clipboards. The notation style, the abbreviations, the way certain letters looped. It was familiar. Too familiar. On the 8th clipboard, I found my own initials at the bottom. Code Team Nurse, LH, my credentials, my signature. But I did not remember that code. I did not remember documenting that case. The date was 10 years ago, early in my tenure at Riverside, but the specifics did not surface in my memory. I had responded to so many codes over the years, dozens, maybe hundreds. They blurred together, a continuous sequence of chest compressions and drug pushes and rhythm checks. I pulled my old employment records, cross-referenced the date on the clipboard. I had been working that night, a 12-hour shift in the trauma unit. But there was no formal incident report filed, no code blue logged in the system. If this code had occurred, it had not been officially recorded. I decided to dig deeper. I accessed the hospital's archived paper records requesting files from that specific month 10 years ago. It took 3 days for the records department to locate the boxes. When they arrived, I spent an entire afternoon sorting through incident reports, patient logs, and staff notes. I found a cluster of unusual documentation, 5 code blues, all within a 2-week span, all occurring in non-patient areas of the hospital. Storage rooms, maintenance closets, staff break areas. Each code documented on paper, never entered into the digital system, all marked with my initials as the responding nurse. I had no memory of any of them. I found witness statements attached to one of the reports, interviews with other staff who had been working those nights. Their accounts described me responding to alarms they had not heard, running toward locations where no code had been called, returning from those areas with clipboards and confused expressions. One nurse described me as disoriented, insisting she had been performing CPR, but her hands were clean, no sweat, no signs of exertion. I read those statements 3 times, my hands shaking. Either I had experienced some sort of dissociative episodes a decade ago, or something else had been happening that I could not explain. The phantom alarms continued. I heard them at least twice per shift now. Always the old tone. Always non-patient locations, always accompanied by documentation from the past. Last week, the nature of the alarms changed. I was walking past the old ICU wing, a section of the hospital that had been closed for renovation 2 years ago. The code blue chime sounded clear and immediate, followed by the voice. Code blue, ICU room 6, code blue, ICU room 6. ICU room 6 had been my assigned room during my first year at Riverside. I had worked that unit before transferring to trauma. I had cared for dozens of patients in that space. I moved toward the closed wing, scanning my badge at the access door. It should not have opened. The area was restricted during construction. But my badge worked. The door clicked open. I walked down the dark corridor, my footsteps echoing on the old tile. The ICU rooms were stripped, empty, walls partially demolished. I reached room 6, the door hung ajar. Inside, the room was gutted. No bed, no monitors, no equipment. But there, on the floor in the center of the space, was a stretcher. Old, rusted, the kind the hospital had phased out years ago. And on the stretcher, covered by a stained sheet, was a shape, a body. I approached slowly, my breath shallow. I reached for the sheet, hesitated, then pulled it back. The body was not fresh. It was desiccated, mummified, as though it had been lying there for years. But it wore a hospital gown, and around its wrist was a faded patient identification band. I leaned closer, trying to read the name. My name, my date of birth, my medical record number. I stumbled backward, the sheet falling from my hands. I looked at the body again, forcing myself to see it clearly. The facial features were distorted, unrecognizable. But the proportions, the build, the length of the limbs, they matched mine. I turned and ran from the room, through the dark corridor, back to the access door. I burst through into the lit hallway of the active ER, gasping, my hands gripping my knees. A colleague approached, concerned. "Are you okay?" "There is something in ICU room 6, I said, struggling to control my voice. "You need to see it." He followed me back, skeptical but willing. I scanned my badge again. Access denied. I tried twice more, denied. "I just came through here," I said. 30 seconds ago. He tried his badge. Also denied. "This area has been locked for months," he said. "Maintenance has the only access." I stared at the door, at the card reader blinking red, refusing entry. "I was just inside," I insisted. He suggested I take a break, get some water, maybe sit down for a few minutes. I nodded, let him guide me back to the staff lounge, but I could not shake what I had seen. I requested access to the hospital's historical employee records, specifically incident reports involving my name. I found one entry dated 9 years ago, a wellness check initiated by my supervisor after I had exhibited confusion and disorientation during shift. The report noted I had been found in the closed ICU wing, attempting to access a room that was no longer in use, insisting I was responding to a code blue that had not been called. I had been sent for a psychological evaluation. The evaluation notes described me as highly stressed, possibly experiencing auditory hallucinations related to occupational burnout. I was given a week off, then cleared to return to work with a recommendation for ongoing counseling. I do not remember any of that. I do not remember being evaluated. I do not remember taking a week off. My memory of that period is seamless, continuous, no gaps that I can identify. But the documentation exists. The reports are there, signed by supervisors I recognize, countersigned by occupational health staff I have worked with. Either I have forgotten a significant psychological episode from my past, or the records are describing something that has not happened yet. Or perhaps something that is happening continuously, looping, repeating, each iteration leaving behind paper trails that I discover later, that I discover now, that I will discover again. The code blue alarms have not stopped. I hear them almost every night. I respond every time, compelled by training and instinct. I find the clipboards, read my own handwriting, see my own initials. And each time, the documented interventions describe the same thing. A patient found unresponsive, resuscitation efforts initiated, no return of spontaneous circulation, time of death called. But there is never a patient name. Never a medical record number, just blank spaces where the identity should be. Last night I heard the alarm again. Code Blue, Trauma Bay 1, Code Blue, Trauma Bay 1. Trauma Bay 1 is my primary work area. I was standing inside it when I heard the call. I was alone. The bay was empty. I looked around, saw nothing out of place. Then I noticed my reflection in the glass cabinet door across the room. I was standing upright, staring at the cabinet. But in the reflection, I was lying on the stretcher, chest exposed, eyes closed. A code team surrounding me, performing compressions, calling for drugs, shocking me with defibrillator paddles. I turned to look at the stretcher, empty. I looked back at the reflection. The code was still in progress. My reflected self still being worked, still unresponsive. I do not know how long I stood there watching myself be resuscitated in a reflection that did not match reality. Eventually, the reflection faded, the code team disappeared, the image returned to normal. Just me, standing alone, staring at glass. Some alarms are not calling for help. They are marking the moment help stopped coming. And some nurses do not respond to codes. They are the codes echoing backward through time, trying to remember when they stopped breathing and started haunting the spaces where they used to work. Story 4. The pediatric ER nurse and the drawing that updated itself. The crayon drawing was taped to the wall in exam room 3. Stick figures holding hands beneath a smiling sun. The kind of cheerful, childish art that parents bring to make the sterile space feel less frightening. But when I returned an hour later to discharge my patient, the drawing had changed. The sun was covered by dark scribbles. One of the stick figures was lying down. And there, in the corner, carefully drawn in red crayon, was a figure that looked unmistakably like me, with exaggerated nurse scrubs and my name badge visible. Beneath it, in uneven child handwriting, she forgot. I have been a pediatric emergency nurse at Greenwood Children's Hospital for 14 years. Working with children requires a different temperament than adult emergency care. Patience, creativity, the ability to comfort while performing procedures that cause pain. You learn to speak in soft voices, to explain medical interventions in terms children can understand, to acknowledge their fear while maintaining calm authority. And you learn to appreciate the small things children bring into these frightening spaces: stuffed animals, picture books, drawings. Parents often bring drawings from home, taping them to the walls or bed rails to make the room feel more familiar. Children create new drawings during their visits using crayons and paper we provide, transforming their anxiety into bright colors and simple shapes. These drawings are ephemeral, left behind when families discharge, discarded by housekeeping when the room is cleaned. They are temporary, forgettable part of the constant turnover of pediatric emergency medicine. But 3 weeks ago, I found a drawing that refused to be forgotten. It appeared in exam room 3, taped to the wall beside the observation bed. I noticed it during a routine patient assessment. A 7-year-old girl with asthma exacerbation, responding well to nebulizer treatments. The drawing was typical of the age group: 5 stick figures holding hands, a large yellow sun in the corner, a house with a red door, green grass rendered as a strip of color along the bottom edge. Cheerful, innocent, the kind of drawing I had seen hundreds of times. I asked my patient if she had drawn it. She shook her head, focused on her breathing treatment. I assumed it had been left by the previous patient, that housekeeping had missed it during room turnover. I made a mental note to remove it after discharge, but quickly forgot as the shift progressed. 8 hours later, I returned to room 3 with a new patient, a 10-year-old boy with a laceration requiring sutures. As I prepared the suture tray, I glanced at the wall. The drawing was still there, but it had changed. The sun was no longer bright yellow. It was covered with heavy black scribbles, obscured, almost aggressive in the force of the crayon strokes. The grass had turned brown, and one of the stick figures, the smallest one, was no longer standing with the others. It was lying down, separated from the group, with red marks around it. I stared at the image, confused. I distinctly remembered the original drawing, the cheerful sun, all 5 figures upright. But now I was looking at something different. I told myself I had misremembered, that my exhaustion was distorting my recollection. I removed the drawing, crumpled it, threw it in the waste bin. 2 days later, I found it again. Same room, same wall, same tape, smoothed out as though it had never been crumpled, but altered further. Now there were 6 figures, 5 original stick people, plus a new one added to the right side of the composition. This new figure was taller, wearing what looked like scrubs rendered in blue crayon, and a rectangular shape on its chest that resembled a name badge. The figure's face had no smile, just 2 eyes and a straight line for a mouth. Beneath the drawing, in shaky child handwriting, "She forgot us." I felt a chill move through me. I removed the drawing again, this time tearing it into pieces before discarding it. I checked with housekeeping to see if they had retrieved it from the trash and retaped it as some sort of prank. They had no knowledge of it. I asked the other pediatric nurses if they had seen children drawing during their shifts. No one had. The drawing reappeared the next night. Room 3, same position, fully intact, no tears, new details added. The stick figure in scrubs now had a face that was more defined. Eyes, nose, mouth, hair. The hair color matched mine. The name badge was more carefully drawn, and though the letters were crude, I could make out my name, Nurse Hale. The figure lying down was now covered with a blanket rendered as a brown rectangle. The red marks around it had expanded, filling the space beneath. New text at the bottom. "She didn't come back." I took a photo of the drawing this time, documenting it before removing it. I sealed it in a plastic bag and locked it in my personal locker. I did not throw it away. I needed to understand what was happening. That night, I accessed the hospital's patient records, searching for any recent pediatric cases in room 3 that had unusual outcomes. deaths, unexpected deteriorations, complaints. I found nothing out of the ordinary. Typical ER cases, asthma, lacerations, fever evaluations, minor injuries, all discharged home or admitted for further care. No red flags. But when I expanded my search to include older records, I found something. 4 years ago, Room 3 had been the location of a prolonged pediatric resuscitation. A 6-year-old boy brought in unresponsive after a near drowning. The code had lasted over an hour. I had been part of the team. I remembered it vaguely. The chaos, the desperate interventions, the eventual decision to call time of death. I pulled the full chart. The child's name was Oliver Brennan. The documentation described the sequence of events: initial assessment, intubation, CPR, medications, rhythm checks, further interventions, continued absence of cardiac activity. Time of death called at 22:37 hours. I read through the nursing notes looking for my entries. I found them. Brief, procedural, documenting the tasks I had performed during the code. But there was a gap, a 7-minute gap between 2 of my documented interventions. 7 minutes where I should have been at the bedside but had not charted anything. I did not remember that gap. I did not remember stepping away. But the timestamps did not lie. I found an addendum note written by the attending physician, added 2 days after the event. It referenced a breakdown in communication during resuscitation and a delayed response to change in patient status. The note was vague, carefully worded, but it implied something had gone wrong. Something had been missed. I searched my memory, trying to reconstruct that night. I remembered the code. I remembered the weight of it, the sadness of pediatric death. But I could not isolate specific moments, could not account for every minute. The drawing appeared again the following night. This time I found it in room 5, not taped to the wall, lying on the stretcher as though someone had placed it there deliberately. The stick figure in scrubs was now positioned away from the other figures, facing in the opposite direction. The figure on the ground was more detailed now, with closed eyes and a flat line drawn above it, unmistakably representing a flat line on a monitor. New text, this time in neater handwriting, as though the child had taken more time. Nurse Hale went to check on someone else. She said she would come right back. She didn't. I felt my throat tighten. I stared at the words, at the accusation rendered in crayon, at the simplicity of the statement that cut through me like a scalpel. I had left the room. I remembered now. During the code, in the midst of the chaos, I had been called to assess another patient, a critical trauma arriving by ambulance. I had told the team I would return. I had been gone less than 10 minutes. When I came back, the resuscitation was continuing, the rhythm still absent, the outcome already determined. But I had left. I had stepped away during a code, and in those minutes, something had shifted. Some intervention had been delayed. Some medication had been administered seconds too late. I pulled the incident reports from that night, the formal reviews conducted after pediatric deaths. There was a note about timing discrepancies, about communication errors, about a critical window where the team had been short-staffed and overwhelmed. No individual was blamed, no formal action taken. Just recommendations for process improvements, additional training, better resource allocation during mass casualty events. But I knew I had been the breakdown. I had been the delayed response. The drawing continued to evolve. I found it every shift now in different rooms, always when I was alone. The details became more sophisticated, more personal. The stick figure labeled as me developed a thought bubble. I'll be right back. The figure on the ground developed a tear falling from its closed eye. The other stick figures, family members I realized, were drawn with mouths open as though calling out. One night I found a new addition. A clock drawn in the upper corner showing a specific time, 22:18 hours. the exact time I had left the resuscitation room to assess the trauma patient. Beneath the clock, she promised. I did not remember promising. I remembered saying I needed to step away. I remembered the attending physician nodding, acknowledging the necessity. But had I said something to the family? Had I reassured them I would be there, that I would not leave their son? I searched my documentation again, looking for any notes I had written about family communication. I found none, but I found notes written by the social worker who had been present. She had documented the mother's distress, her repeated requests for the nurse who was here at the beginning to come back. She had documented explaining that the nurse was managing another critical patient. She had documented the mother's response. But she promised she wouldn't leave him. I sat in the staff lounge, staring at those words on the screen, feeling the weight of a memory I had buried or suppressed or genuinely forgotten. I had promised. I had stood beside that mother in the first minutes after her son arrived, had held her hand while the team intubated him, had told her I would be there with him, that I would not let him be alone. And then I had left. Because another patient needed me. Because that is what triage requires, because I could not be in two places at once. But to that mother, to that child, the promise had been broken. The drawing appeared one final time last night. I found it on my locker in the staff changing room, taped to the metal door. I do not know how it got there. The changing room is secured, accessible only by badge. This version was the most detailed yet. The stick figure representing me was now drawn with a shadow, a dark shape beneath it, as though the figure were sinking or being pulled downward. The child on the ground was no longer alone. There were other small figures around him now, also lying down, also with flatline monitors above them. 5 children total. I counted back through my years in pediatric emergency, trying to remember other cases where I had stepped away, where timing had been critical, where outcomes might have been different if I had stayed. I found 5 cases where I had been called to other emergencies, where I had triaged and chosen to respond elsewhere, where children had died while I was managing someone else. 5 children, 5 broken promises. The drawing included all their names now, written carefully in the corner. Oliver, Emma, Jacob, Lily, Noah. I remembered all of them. I had buried the memory of each, had rationalized my decisions, had reminded myself that I had done what was required, what any nurse would have done given the circumstances, but the drawing would not let me forget. At the bottom, in the neatest handwriting yet, we are still waiting for her to come back. I removed the drawing from my locker and carried it to room 3. The room was empty, clean, prepared for the next patient. I taped the drawing to the wall in the same spot where I had first found it. I stood there looking at the images, at the names, at the stick figure that represented me. I am sorry, I whispered. I am sorry I left. I am sorry I did not come back. The room remained silent. The drawing did not change, but as I turned to leave, I felt something, a small hand slipping into mine, a child's grip, gentle and forgiving. I looked down. No one was there, but the sensation remained warm and real, as though someone had accepted my apology. I worked my shift, I cared for my patients, and when I returned to room 3 hours later, the drawing was gone. It has not reappeared since. But sometimes when I walk past that room, I see small shadows inside, shapes that move in my peripheral vision, children who wait patiently for someone to remember them, to acknowledge the promises that were broken, to understand that in emergency medicine, every decision to step away from one patient is a decision to leave someone behind. Some drawings are not art. They are testimony, and some children do not forget, even after their families have moved on and the hospital has archived their charts and the nurses have learned to stop thinking about the ones who did not survive. Story 5. The float nurse's endless intake form. The electronic intake form loaded on my screen like any other. Standard fields for patient demographics, medical history, and current medications. I filled it out methodically, hit submit, and watched the confirmation message appear. But instead of closing, the form refreshed, generating a new section I had not seen before. Childhood illnesses, the header read. I scrolled down. Traumatic events, ages 5 to 10. Further down, recurring dreams. And at the bottom, a field labeled, Things You Have Tried to Forget. My cursor blinked in the empty space, waiting. Floating is a necessity in hospital nursing. When one unit is understaffed and another is overstaffed, nurses are reassigned, floated, to maintain safe patient ratios across the facility. I have been a float nurse at Mercy Regional for 6 years. Moving between departments as needed, adapting to different workflows, learning the subtle variations in charting systems and protocols. Floating requires flexibility, quick learning, and the ability to function without deep familiarity. You arrive, receive brief orientation, and begin working. 3 weeks ago, I was floated to the ER, a unit I had worked in only twice before. The night shift supervisor handed me a condensed orientation packet, locations of supplies, emergency protocols, key phone numbers. She assigned me to the fast-track area, the section for lower acuity patients with minor injuries and illnesses. Straightforward cases, simple documentation. At 2300 hours, I logged into the electronic charting system using the temporary credentials provided for float staff. The system accepted my login and loaded the patient tracking board. 2 patients were already assigned to me, a laceration repair and a possible urinary tract infection. I clicked on the first chart to begin my assessment documentation. The intake form loaded. Standard format: name, date of birth, medical record number, chief complaint, vital signs, medications, allergies. I filled in the required fields, documenting the information the patient had provided during triage. When I completed the final section, I clicked Submit and Lock. The system processed for a moment, then displayed Form submitted successfully. Additional sections now available. The screen refreshed. A new section appeared. Extended medical history. I frowned. I had not seen this section before. I clicked on it, assuming it was a specialized module used in this ER. The section expanded, revealing fields I did not recognize. Childhood illnesses detailed. Family medical history, 3 generations. Psychological history. Social determinants of health, comprehensive. These were not standard intake questions. They were far too detailed, too invasive for an emergency visit. But the system indicated they were required fields, marked with red asterisks. I could not advance without completing them. I returned to the patient, a man in his 30s with a minor hand laceration. I need to ask a few more questions, I said. The system is requesting additional medical history. He looked confused but cooperative. I began asking the questions listed on the form. Had he experienced any significant illnesses as a child? Did he have family history of genetic conditions? Any history of mental health treatment? He answered what he could, growing increasingly uncomfortable with the personal nature of the questions. When I reached the section labeled Traumatic Events Detailed Chronology, he stopped me. "Why do you need to know this?" he asked. "I am here for a cut on my hand." "I apologize," I said. "The system is requiring this information. I will check with my supervisor to see if we can skip these sections." I excused myself, returned to the central workstation, and pulled up the form again. The sections had expanded further. New fields had appeared, questions I had not seen moments before. Earliest memory. Description of childhood home. Names of elementary school teachers. First significant loss. I clicked the help icon, searching for information about this extended intake module. The help text read, "This form adapts based on user credentials. Certain roles trigger enhanced data collection protocols. Please complete all fields to proceed." I logged out and back in, thinking my credentials might be malfunctioning. The system accepted my login. I opened the patient chart again. The form was still there, even longer now. New sections cascading down the screen faster than I could read them. Recurring dreams. Unresolved conflicts. Things you have tried to forget. I scrolled back to the top, looking for a way to exit or minimize the form. There was no close button, no cancel option, just the endless fields and the blinking cursor waiting for input. I called the supervisor, explained the situation. She came to my workstation, looked at my screen and frowned. "I am not seeing what you are describing," she said. "This looks like the standard intake form to me." I pointed at the fields. "These sections. Do you see them?" She leaned closer, squinting. "I see name, date of birth, chief complaint, the usual fields. Are you sure you are on the right screen?" I looked at my monitor again. The extended sections were still there, clearly visible, but her expression told me she was not seeing them. "Maybe it is a display issue," she said. "Try logging in from a different terminal." I moved to another computer, logged in, opened the same patient chart. The form loaded, same extended sections, same questions. Things you regret, lies you have told, people you have hurt. I stared at the screen, my hands hovering over the keyboard. These were not medical questions, these were confessional prompts. But they were required fields. The system would not let me proceed without answering them. I filled in generic responses, vague non-answers designed to satisfy the form without revealing anything real. No significant regrets, no major lies, no intentional harm caused. I clicked submit. The form processed, then refreshed. The sections I had just completed were still there, but now they contained different text. Not my generic responses, detailed, specific answers written in first person, describing events from my life that I had not typed. In the things you regret section, I regret not calling my mother the week before she died. I told myself I was too busy. I told myself I would call the next day. She died before I made the call. That was true, that had happened, but I had not written it. I scrolled to the lies you have told section. It contained a full paragraph describing a situation from 5 years ago, when I had documented care I had not actually provided. Vital signs I had estimated rather than measured, an assessment I had abbreviated because I was overwhelmed. The documentation had been accepted. No one had questioned it, but I had known it was falsified. I had never told anyone about that. I had buried it, convinced myself it was a minor shortcut, that everyone did it occasionally under pressure, but the form knew. I tried to delete the text, to overwrite it with something else. The fields were locked. I could not edit them. I could only read them. I clicked submit again, desperate to close the form and return to normal charting. The system processed, then displayed. Additional sections now available. The form expanded. New fields appeared. Times you have felt afraid. Moments you have pretended to be confident. Patience you have failed. I stood up from the terminal, backing away. The supervisor approached again, concerned. "Are you okay?" "I need to stop using this system," I said. "There is something wrong with it." She looked at the screen, still seeing nothing unusual. "Just take a break. We can reassign your patients to someone else if you are not feeling well." I nodded. Left the workstation, went to the staff lounge. I sat in the quiet room trying to calm my breathing, trying to rationalize what I had seen. Software glitch, database error, corrupted user profile. But I knew what I had read. I knew those details were accurate, personal, things no system should have access to. After 20 minutes, I returned to the ER. My patients had been reassigned. I was given new cases, a child with fever, an elderly woman with chest pain. I logged into the system, determined to complete my shift without incident. The intake forms for these new patients loaded normally at first. Standard fields, routine questions. I completed them, submitted them, and began my assessments. But within an hour, the extended sections began appearing again. This time, they were not about the patients. They were about me. Describe the last time you felt competent. List the shifts where you have made errors. Name the patients whose outcomes might have been different if you had acted differently. I stopped charting. I closed the screens, logged out, and asked the supervisor if I could switch to paper documentation for the remainder of the shift. She agreed, puzzled but accommodating. I completed my shift using paper forms, handwriting my notes, avoiding the electronic system entirely. When I left at 0700 hours, I felt a temporary relief. But when I arrived home and opened my personal laptop to check my email, the form was there, loaded in my browser, same extended sections, same personal questions. Things you have hidden. Versions of yourself you have abandoned. Selves you might have been. I closed the browser. The form remained, overlaying my desktop as though it were a pinned window. I restarted the computer. When the system rebooted, the form loaded automatically, filling the screen before any other applications opened. I tried to uninstall my browser. The form persisted. I tried to restore my system to an earlier backup. The form remained. I stopped using my personal devices. I returned to work the next night, hoping the issue was limited to my home network. But when I logged into the hospital system, the form was waiting. It had grown longer. Sections now included memories you have repressed, truths you have avoided, people you have pretended not to recognize. Each section contained pre-filled answers written in my voice, describing things I hadn't consciously remembered, but that felt undeniably true once I read them. I began recognizing a pattern. The form was not asking me questions, it was documenting me. It was creating a comprehensive chart of my internal life, compiling data I had never formally recorded but that existed somewhere in my memory, my behavior, my history. I searched the hospital's IT records looking for information about this intake module. I found references to a pilot program launched 2 years ago, an adaptive charting system designed to collect comprehensive patient histories by analyzing user behavior, keystrokes, and response patterns. The program had been decommissioned after 6 months due to data integrity concerns and unexpected outputs. But it had not been fully deleted. Fragments of the code remained embedded in the system, activating under certain conditions, specifically when float nurses with temporary credentials accessed the database. I requested a meeting with IT, explaining what I was experiencing. They reviewed my user profile, ran diagnostics, and found anomalies. My login was triggering legacy subroutines, causing the adaptive system to treat me as both the user and the subject. The system was charting me, not my patients. They attempted to purge my profile, to remove the corrupted data and reset my credentials. The process failed. The form persisted. It documented the issue, escalated it to their vendor, and suggested I stop using the electronic charting system until a fix could be implemented. But the form had already spread beyond the hospital network. It appeared on every device I used, my phone, my tablet, public library computers. It followed me, expanding, documenting, compiling a version of my life that was more complete than my own memory. Last week, the form generated a new section. Futures you will not experience. It contained descriptions of alternate timelines, career paths I had considered but not pursued, relationships I had ended, decisions I had avoided. Each description was detailed, plausible, written as though it had already happened. I read them with a sick fascination, recognizing elements of desires I had suppressed, possibilities I had dismissed. And at the end, a final section. Current status. The section described my present life, my work as a float nurse, my isolation, my routine. But it was written in past tense, as though I had already finished, as though this version of me had been completed and closed. Beneath that, disposition, unresolved. I do not know if the form will ever finish. I do not know if there is a final section, a submit button that will close it permanently, or if it will continue generating new fields indefinitely, documenting every thought, every regret, every unlived possibility until there is nothing left of me that has not been charted. Some systems are designed to document patience. But some systems cannot distinguish between the patient and the practitioner. And once the charting begins, once the form starts compiling your history, it does not stop until it has documented every version of you that ever existed and every version that never did. Story 6. The patient who spoke in staff badges. He sat on the edge of the exam table, silent, staring at the floor. When I approached to introduce myself, he reached for the ID badge clipped to my scrubs and tapped it 3 times. Deliberately, rhythmically, like a code. My badge scanner chirped, the screen lit up and displayed a staff profile I did not recognize. Anderson, M. Status, transferred, unknown facility. I looked at the patient. He tapped again. Another profile appeared. Chen, L. Status, left without notice. Tap, tap, tap. 6 more profiles. 6 more staff members I had never met, all marked with ambiguous exits, all missing. I have been a behavioral health nurse in the emergency department at Riverside Psychiatric Center for 11 years. The behavioral wing is a specialized section of the ER designed for patients experiencing psychiatric crises, acute psychosis, suicidal ideation, violent ideation, severe panic, dissociative episodes. We provide stabilization, assessment, and connection to long-term mental health resources. The work requires patience, calm demeanor, and an ability to interpret communication that is often fragmented, metaphorical, or nonverbal. Many of our patients cannot speak coherently. Some are mute due to catatonia or trauma. Others communicate through gestures, repeated phrases, or compulsive behaviors. We learn to read body language, to interpret patterns, to understand what is being expressed even when words fail. But 3 weeks ago, I encountered a patient whose communication method was unlike anything I had seen before. He arrived via police transport at 01:30 hours on a Thursday morning. The officer's report described him as unresponsive to verbal stimuli, found wandering near the hospital campus, no identification, no known residence. Estimated age mid-30s, no signs of injury or intoxication, just silent, directionless walking. We admitted him to the behavioral unit under a 72-hour psychiatric hold, assigned him to observation room 4. I was the nurse on duty. I entered the room to begin the intake assessment. He was sitting on the edge of the exam table, hands resting on his knees, staring at the floor. His clothing was unremarkable. Jeans, gray sweatshirt, worn sneakers, no visible distress, no agitation, just stillness. "Hello," I said, keeping my voice calm and even. "My name is Meredith. I am a nurse here. I am going to ask you some questions to help us understand how we can support you." He did not respond, did not look up, did not acknowledge my presence. I continued, asking standard screening questions. "Can you tell me your name? Do you know where you are? Do you feel safe? Are you having thoughts of harming yourself or others? No response. I documented his presentation. Patient nonverbal. No eye contact. No response to verbal stimuli. Appears calm but withdrawn. As I wrote, he moved. A slow, deliberate motion. He reached toward me, not aggressively, but with focused intent. His hand extended toward the ID badge clipped to my scrubs. I instinctively stepped back, maintaining professional distance. But he persisted, his hand still reaching, his eyes now fixed on the badge. I unclipped it, held it at a distance so he could see it without making physical contact. "Is this what you want to see?" I asked. "My badge?" He nodded. Once. Clear. I held it closer. He reached out and tapped it. 3 deliberate taps, his fingertips striking the badge's surface with rhythmic precision. My badge scanner chirped. I had not realized it was active. The small screen on the back used for scanning access cards and verifying credentials lit up. A staff profile appeared. Name: Anderson Michael. Role: Psychiatric Technician. Department: Behavioral Health. Status: Transferred unknown facility, last active 14 months ago. I stared at the screen. I did not recognize the name. I had never worked with a Michael Anderson. I looked at the patient. He was watching me now, his eyes focused, waiting. "I do not know this person," I said carefully. "Do you?" He tapped again, 3 times. The scanner chirped. A new profile appeared. Name: Chen, Laura. Role: Behavioral Health Nurse. Department: Psychiatric Emergency. Status: Left without notice. Last active 9 months ago. I felt a chill. Laura Chen. The name was vaguely familiar. I thought I remembered hearing about a nurse who had resigned suddenly, who had left mid-shift and never returned. But I had not worked directly with her. I had only heard rumors. The patient tapped again. Name: Briggs Stephen. Role: Security Officer. Department: Hospital Security. Status: Terminated, cause unspecified. Last active 6 months ago. Tap. Name: Patel Anisha. Role: Psychiatric Resident. Department: Emergency Psychiatry. Status: Transferred unknown facility. Last active 11 months ago. Tap. Name: Kowalski Daniel. Role: Crisis Counselor. Department: Behavioral Health. Status: Left without notice. Last active 7 months ago. He continued tapping. Each time a new profile appeared. All staff from the Behavioral Health Department. All marked with ambiguous exits, transferred to unknown locations, left without notice, terminated without specified cause. None of them currently employed at Riverside. I counted 12 profiles before he stopped. "I do not understand," I said. "How are you doing this? How is my scanner displaying these profiles?" He did not answer. He simply pointed to the scanner, then to himself, then back to the scanner. I checked the device. It was a standard hospital-issue credential scanner used by security and administrative staff to verify IDs and access permissions. I had been issued one as part of my role in behavioral health, where we frequently needed to verify identities of patients, visitors, and outside agency personnel. But it should not be accessing archived staff records. It should not be displaying profiles of employees who no longer worked here. I reported the incident to the night supervisor, showed her the scanner, explained what had happened. She reviewed the device, scrolled through the displayed profiles, and frowned. "These records should not be accessible from a floor-level scanner," she said. "This device should only pull active staff data. I will report it to IT." She took the scanner, replaced it with a standard one from the supply cabinet, and told me to continue with the patient assessment. I returned to room 4. The patient was still sitting on the edge of the table, still silent. I attempted further communication, asking if he could write, if he could use gestures, if he could nod or shake his head to respond to yes or no questions. He did nothing. He just stared at my new badge scanner, waiting. Against my better judgment, I unclipped it and held it toward him. He tapped it 3 times. The scanner chirped. A profile appeared. Name Ellis Meredith. Role behavioral health nurse, department psychiatric emergency. Status active, last active, current. My profile, my information. But beneath the standard fields, there were additional entries I had never seen before. Incident reports filed, 7. Patient complaints, 3. Unresolved safety concerns, 5. I scrolled down. More fields appeared. Disciplinary warnings, 2. Psychological fitness evaluations, 4. Mandatory leave periods, 1. I stared at the screen. Some of these entries were accurate. I had been involved in incident reports, standard documentation after patient safety events. But others did not match my memory. I did not recall any disciplinary warnings. I had never been placed on mandatory leave. I looked at the patient. He tapped again. The profile expanded. New sections appeared. Detailed notes written in clinical language, describing concerns about my performance, my interactions with patients, my mental state. Staff member exhibits signs of emotional exhaustion. Recommend monitoring. Incident involving patient restraint. Staff member's judgment questioned. Concern raised regarding staff members' boundary management with patients. These were fragments from supervisor evaluations, peer reviews, and incident debriefs. Documents I had never seen in full. Pieces of my employment record that existed behind administrative walls. The patient tapped again. The profile updated, adding a new field at the bottom. Projected status, transferred, unknown facility, estimated timeline, 4 months. I felt my breath catch. What is this supposed to mean? I asked. The patient finally spoke. His voice was quiet, hoarse from disuse. They all saw it before they left. Saw what? Their profiles, their futures, the badges tell you when you are going to disappear. I stepped back, my hands shaking. Who are you? I was security, he said. I saw my profile 6 months before I left. I tried to ignore it, I tried to change it, but the badges do not lie. When they say you are going to transfer to an unknown facility, it means you are going to leave and no one will know where you went. Or why. That does not make any sense, I said. Profiles are just data. They do not predict the future. They do when the system is already decided, he said. The hospital knows who is going to leave. It knows who is going to break. It tracks us, documents us, marks us for exit before we even realize we are failing. I looked at my scanner again, at the projected status field, at the 4-month timeline. This is not real, I said. This is a system error. Check the others, he said. The ones I showed you, look them up. See what happened to them. I left the room, went to the administrative office, accessed the personnel database. I searched for the names he had revealed. Michael Anderson, employed as psychiatric technician, resigned after 14 months. Exit interview noted, personal reasons relocating to undisclosed location. Laura Chen, employed as behavioral health nurse, resigned abruptly, no exit interview. Supervisor notes indicated increasingly erratic behavior, failed to report for scheduled shifts, did not respond to contact attempts. Stephen Briggs, employed as security officer, terminated. Disciplinary file referenced policy violations and unprofessional conduct. No further details. One by one, I checked them all. 12 staff members. All had left within the past 2 years. All had ambiguous, incomplete separations. None had left forwarding information. I returned to room 4. The patient was lying down now, curled on his side, facing the wall. Why are you telling me this? I asked. Because you still have time, he said. You still have 4 months. You can leave on your own terms. You can disappear in a way you choose. I am not disappearing, I said. I am not leaving. He did not respond. Over the following week, I tried to forget the conversation, to rationalize it as delusional content from a psychiatric patient. But I could not stop thinking about the profiles, about the pattern of exits, about my own projected timeline. I began noticing things I had previously ignored, vague comments from supervisors about my stress levels, suggestions that I take time off, offers for counseling services I had not requested. I reviewed my performance evaluations, looking for signs that I was being prepared for separation. I found nothing explicit, but the language was cautious, qualified, laced with concerns about sustainability and wellness. Last week, I accessed my badge scanner again, checked my profile. The timeline had updated. Projected status transferred unknown facility. Estimated timeline 3 months. 1 month had passed. The countdown was accurate. I tried to find the patient, to ask him more questions, to understand what was happening. But he had been discharged. The chart indicated he had been transferred to a long-term psychiatric facility, but the destination was listed as external partner location undisclosed. I called the facility coordinator to request transfer details. She had no record of the transfer. The patient had simply been removed from our census, his chart closed, his location unknown. I do not know if I will stay or leave. I do not know if the timeline is fixed or if I can change it. But I know that every time I scan my badge now, the countdown continues. 3 months, then 2, then 1. And I know that somewhere there is a list of staff who are marked for exit, whose profiles have been pre-written, whose disappearances have already been documented before they occur. Some systems do not just track employees, they archive them, categorize them, decide when they have outlived their usefulness. And some patients are not patients at all. They are messengers sent to warn the ones who are next. Story 7. The Resuscitation Nurse's Corridor of Returned Patients. I had just finished a 40-minute resuscitation attempt. Failed. Time of death called at 03:17 hours. I walked back toward the central station, exhausted, covered in the residue of emergency medicine. But the corridor I entered was not the one I had left. The walls were lined with patient monitors, 12 of them, each displaying a distinct cardiac rhythm. I recognized every pattern immediately, not because they were generic, but because I had seen them before. Each rhythm belonged to a patient I had lost. Each monitor showed the final 30 seconds before I had stopped compressions and called the code. And as I walked forward, the rhythms began to sync with my own heartbeat. My pulse controlling theirs, my steps drawing them closer together into a single unified flatline. I have been a resuscitation nurse in the critical care emergency department at Lakeview Memorial Hospital for 16 years. My role is specialized. I respond to codes, manage airway emergencies, coordinate high-acuity traumas. I am trained to make rapid decisions under pressure, to perform advanced interventions, to lead teams through the chaos of life-threatening events. I am comfortable with death. I understand that not every resuscitation succeeds, that some injuries and illnesses are incompatible with survival, that calling a code is sometimes the most compassionate decision. But I have never become comfortable with failure. I carry the weight of every unsuccessful resuscitation, every patient whose rhythm I could not restore, every family I had to face after calling time of death. I remember their faces, their names, the specific sequences of interventions I performed. I replay those moments, analyzing my decisions, wondering if different timing or different medications or different compressions might have changed the outcome. I thought that weight was private, internal, something I managed alone in the quiet hours after my shifts ended. But 3 weeks ago, I discovered that the hospital has been keeping its own record. A corridor built from my failures, a space where the patients I could not save have been waiting. It began after a particularly difficult resuscitation. a 62-year-old man brought in by ambulance after collapsing at home. Witnessed cardiac arrest, bystander CPR initiated, paramedics arrived within 6 minutes. Good conditions for survival. We worked him for 40 minutes. Intubation, IV access, epinephrine, rhythm analysis, defibrillation, continued compressions, additional medications. But his rhythm never converted. Asystole persisted. After 40 minutes, the attending physician looked at me and nodded. I confirmed the time, 03:17 hours. I called the code. The team dispersed. The family was notified. I stayed behind to prepare the body, to document the interventions, to clean the resuscitation bay. Standard procedure. I have done it hundreds of times. When I finished, I walked out of the bay and turned left toward the central station. But the corridor was wrong. I had been working in this ER for 16 years. I knew every hallway, every room, every access point. But the corridor I entered was not familiar. It was narrower than standard hospital width, the lighting dimmer, the walls lined with equipment I did not immediately recognize. I stopped, disoriented. I turned back toward the resuscitation bay, intending to retrace my steps, but the door I had just exited was no longer there. The wall was seamless, unbroken, as though the bay had never existed. I looked forward down the unfamiliar corridor. It extended farther than it should, longer than the physical dimensions of the building would allow. And along both walls, spaced at regular intervals, were patient monitors. 12 in total, 6 on each side. Each monitor was active, displaying a cardiac rhythm. I approached the first monitor slowly, cautiously. The screen showed a rhythm I recognized immediately. Ventricular fibrillation, chaotic, incompatible with life. But it was not generic. It was a specific pattern, a specific rate, a specific morphology. I had seen this exact rhythm before. I moved to the second monitor. Pulseless electrical activity, organized complexes without mechanical function. Again, specific, familiar, third monitor. Asystole, flat line with occasional artifact. I walked the length of the corridor, examining each monitor. 12 rhythms, 12 patients. And as I studied each one, memory surfaced. Names, faces, dates. The first monitor, Gregory Hartman, 71 years old. Cardiac arrest during dialysis. We worked him for 38 minutes. I had intubated him, managed his airway, pushed medications. We could not convert his rhythm. I called the code. Second monitor, Jessica Alvarez. 44 years old, massive pulmonary embolism, 26 minutes of resuscitation. I had coordinated the team, directed compressions, administered thrombolytics. No response. I called the code. Third monitor, Paul Novak, 59 years old, witnessed arrest in the ER waiting room, 31 minutes. I had been first to respond, had initiated CPR, had run the code. Asystole throughout. I called the code. I recognized all 12, all patients I had worked with in the past 3 years. All unsuccessful resuscitations, all codes I had called. I stood in the center of the corridor, surrounded by the rhythms, feeling my own heart beating in my chest. And as I focused on my pulse, I noticed something impossible. The rhythms on the monitors were changing. Not randomly, they were synchronizing. Each screen was adjusting its rate, its timing, aligning with my heartbeat. I felt my pulse quicken with anxiety. The rhythms accelerated. I forced myself to breathe slowly, to calm down. The rhythms slowed. They were reflecting me. The monitors were not displaying historical data. They were tracking my physiological state, mirroring my cardiac output, responding to my presence. I started walking, looking for an exit, for a door back to the familiar ER. But as I moved, the monitors followed. Not physically, they remained mounted on the walls. But the rhythms tracked my movement. As I passed each screen, the rhythm displayed would intensify. the waveforms growing larger, more prominent, as though the patient represented by that monitor were trying to capture my attention. I reached the end of the corridor. There was a door, unmarked, industrial gray. I pushed it open. Beyond was another corridor, identical layout, more monitors, 12 more rhythms. I recognized these too. Older cases, patients from 4 and 5 years ago, some names I struggled to recall fully, but the rhythms were unmistakable. Each one a failure, a resuscitation I could not complete. I walked through that corridor to the next door. Another hallway, more monitors, cases from 6 and 7 years ago. I lost count of how many corridors I passed through. Each one contained 12 monitors, each monitor representing a patient I had lost. The hospital was archiving my failures, cataloging them, building a physical record of every unsuccessful code I had run. Eventually, I reached a corridor that was different. The monitors here were blank, screens dark, waiting. I counted them. 12 empty monitors. 12 failures I had not yet experienced. 12 patients I had not yet lost. I turned and tried to run back, to retrace my path, to find my way to the familiar ER. But the corridors had changed. The doors opened into different sequences. The monitors displayed different rhythms. I was lost inside a structure that should not exist, surrounded by the records of deaths I could not prevent. I do not know how long I walked. Time felt distorted, unreliable, but eventually I found a door marked Exit. I pushed through it and emerged into the main ER corridor. The familiar brightly lit hallway, the normal sounds of the department around me. I checked my watch. 03:41 hours. 24 minutes had passed since I left the resuscitation bay. I was standing near the central station, exactly where I had been heading when I first entered the strange corridor. I asked a colleague if she had seen me in the past half hour. She looked confused. "You have been at the station with me the whole time," she said. "You have been charting the code documentation." I looked at my computer screen. The resuscitation documentation was open, nearly complete. Timestamps showing I had been working on it for the past 20 minutes. But I had no memory of typing any of it. I finished the chart mechanically, closed the record, and tried to focus on the rest of my shift. But I could not shake the feeling that part of me was still in that corridor, still walking past those monitors, still confronting the accumulation of my failures. 2 nights later, I had another unsuccessful resuscitation. 80-year-old woman, massive stroke, unwitnessed downtime, poor prognosis from the start. We worked her for 22 minutes before calling the code. When I left the room and turned toward the central station, I entered the corridor again. This time, there were 13 monitors in the first hallway. The new patient had been added. I walked faster this time, trying to move through the corridors quickly, trying to find the exit. But the structure had grown. More hallways, more monitors. And now the rhythms were not just synchronizing with my heartbeat, they were merging. As I walked, the 12 rhythms in each corridor began to converge, the individual patterns blending into a single unified waveform that played across all screens simultaneously. And that unified rhythm was tightening, compressing, the intervals between beats shortening, the rate accelerating beyond any sustainable cardiac output. I realized what was happening. The corridor was not just showing me the patients I had lost. It was showing me what happens when you carry too many failures, when the accumulated weight of death compresses your own rhythm, when the patients you could not save begin to merge with your own physiology. I reached the section with the blank monitors, the ones representing failures I had not yet experienced. But they were no longer blank. They were displaying a rhythm now, my rhythm. My name was listed beneath each screen, my medical record number, my vital signs. 12 versions of me, 12 future failures, 12 iterations where I would be the patient, where someone else would run the code, where my rhythm would fail to convert. I tried to leave, but the exit doors were locked. I was trapped inside the archive of my own inadequacy, surrounded by the evidence that I was not good enough, that I had never been good enough, that eventually I would join the monitors as one more unsuccessful resuscitation. I sat down in the center of one corridor, surrounded by the synchronized rhythms, and waited. I did not know what I was waiting for. Expulsion, collapse, acceptance. And then I heard footsteps. Slow, deliberate, approaching from behind me. I turned. A figure was walking down the corridor, a patient dressed in a hospital gown, barefoot, moving with the careful gait of someone recently deceased. I recognized the face. Gregory Hartman, the first patient on the first monitor. He stopped a few feet away from me, looking down at me with an expression that was not angry or accusatory, just tired. "You carry us," he said quietly. "I tried to save you," I whispered. "I did everything I could." "I know," he said, "but you did not let us go. You kept us here, in your memory, replaying us, trying to find what you did wrong. You built this place. You built these corridors. You made the monitors. We are just reflections of what you will not release." I looked around at the screens, at the rhythms that were still synchronized with my pulse. "How do I let you go?" I asked. "You stop calling the codes," he said. "You stop taking responsibility for deaths that were not yours to prevent. You recognize that we were already gone before you ever touched us." "But I am supposed to save people," I said. "That is my job." "Your job is to try," he said. "Not to succeed every time, not to carry the ones you could not save. You are not a failure because we died. You are just human." He turned and walked back down the corridor, his figure fading into the dim light. One by one, the monitors began to turn off, the rhythms disappearing, the screens going dark. The corridors shortened, contracted, collapsing back into the normal dimensions of the hospital. When I opened my eyes, I was sitting on the floor near the central station. My colleague was kneeling beside me, concerned. "Are you okay?" she asked. "You just sat down and zoned out. I've been trying to get your attention for the past minute." I nodded slowly. "I think I am okay. I finished my shift. I completed my documentation. And when I left the hospital that morning, I did not look back at the resuscitation bay, did not mentally replay the failed code, did not add another name to the list I had been keeping in my mind. I do not know if the corridor still exists, if it waits for me when I next run an unsuccessful resuscitation. But I know that if I enter it again, I will not be building it anymore. I will be dismantling it, one monitor at a time, one patient at a time, learning to let the dead rest instead of carrying them with me into every future code. Some corridors are not built by hospitals. They are built by caregivers who cannot forgive themselves for being human. And some patients do not haunt us because they are angry. They haunt us because we will not let them go.